Focusing on the AFib, we are focusing on the AFib-related thrombogenesis. So we want to prevent it not only about the anticoagulation, also we can do the interventional therapies. The AFib is because more than 90% of the thrombi in AFib patients originate from the LAA. So that's why we think the closure of the LAA could prevent the stroke. So that's the basic of the LA closure. Appendage varies very much. You can see a lot of type of appendage, and the most important thing is the appendage is close to our pulmonary veins, and there is ridge side and there is mitral valve annulus. So that's the key important anatomic features of the LAA when we do the procedure. So we do some combined procedures, combine the AFib ablation and appendage closure. So how about the story in Japan? Do you do combination procedures?
No, right now the Watchman is watching the Greenberg file, and we have not the official approved devices to use the
Okay, sure. So in China, some centers, including us, we do combination procedures, ablation and a closure in one procedure. So here is the anatomy of the appendage, we all know, and here is the angiogram. Angiogram of the appendage, you can see from different views. Usually we do the angiograms in two projection views, from the right anterior oblique and plus the caudal or cranial, two views. Of the appendage, there are cactus and cauliflowers and chicken wings and wing stalks. And between appendages, some clinical data showed that the morphology of the cauliflowers are the most dangerous one. There are very high prevalence of the risk of thrombus for patients. But for chicken wings, maybe are much safer. Among these four morphologies, the windsock and the cactus, we can see them. But maybe sometimes the cauliflowers are have the very large orifice, so that might be the difficult for our closure procedures. So in this slide, I will show you one case with a very huge, just like the cauliflower-like appendage, very huge ostium, and which we can only do LAmbre. Okay. Appendage closure, and it is recommended as Class 2B, Level B evidence in the recently published guidelines from Europe. And we have some consensus in China, Chinese edition, the similar indications for the appendage, mostly used in the prevention in patients with the very high risk of thrombosis. We do Charles Vascular score, maybe more than 3 score and points, and some high risk of bleeding, right? So, or we're in patients with contraindications or reluctant to the chronic anticoagulation center. Enrolled in our center, the Charles Vascular score is more than 3, and sometimes you can see, in Asian patients. It's very easy to encounter patients with more than 5, 6, even 7. Yeah, this scores patients. So here we have the new one, the novel device, LAmbre, and we can compare these 3 devices later in the slides. So, because you are experts of, I think most doctors doing the closure are expertise in the Watchman devices. So when we use the Watchman devices, we will question some issues. For sometimes you need to deep seated the sheets into the end of the appendage, right? So this is very thin wall, so that's a high risk of perforation. So it is very difficult to close the multi-lobe LAA appendage. So for these two lobes cases, for one Watchman device, maybe it's not easy. So we can only choose one lobe and use a larger device, and we choose the better access angle, and we did that. Or some doctors can do the kissing devices techniques. Yeah, maybe Dr. Yu is a Chinese doctor in German. He's very famous doing this kissing techniques. So, but we don't do that because you always can have some leaks around the appendage. It's not only the shoulder protrusion. We are care about the embolization, right, of the device embolization. So if you use Watchman device, you can recapture and you can reposition. But sometimes for this device, the second or the third time you do the reposition, you will find, oh, this device is straight, is pressed by the appendage. So it is very difficult for you to get a very good position or satisfied position in the third or fourth try. So here we still have some risk of device embolization. Here we can have another option about the ACP devices. But when we use this device, this is much safer. In our opinion, it's much safer than Watchman. But still, this low band plus disc-like disc structure device, we worry about the affecting of the surrounding structures, something like the mitral valve, and sometimes we care about the circumflexus arteries. So it is also being difficult for multiple recapture for this device because it's very stiff. And the risk of device embolization, still, we have that risk, but we don't have that case in our center. But yeah, we have read some reports about this device embolizations with ACP. So this is the LAmbre. This is the first generation. It's better, it's shorter, and maybe good compatibility for the appendage. The size of the lobe and disc, it's fixed. You don't have much more choices. Options, but with the new LAmbre system, we have three parts, main three parts. The proximal part is the cover disc, and here we have the connection ways, and here is umbrella. That's why we call it a LAmbre. That's LA umbrella, right? There's umbrella in the LA to protect you from the history. Okay, that's their advertisement. So this umbrella-like. So in the top of the umbrella, we have 8 small hawks, and they have the double-layered PET membrane. I don't know what's the PET, but it's very good material to make the small profile. I will introduce that later. And we have the cover disc. In the part and the umbrella. This is the umbrella frame. I have 2 choices of the delivery systems. 2 curves. This is double curved system, and this is the single curve system. You can do that with your different transseptal puncture and different location of the appendage. First one is suitable for Barrel's anatomy. Second one, we have the stable anchoring mechanisms. And you can fully recapture and redeployable in the appendage. And the profile of the delivery sheets is very low, so it's better for the patients, and it is much rapid endothelialization. So in the clinical trials, no patient will reject for this umbrella designed for both or even more complicated anatomy of the appendage. Our decision, I think, we have 2 choices. This is the standard design one, and this is the special design. So this is mainly for the single lobe LAAs. The umbrella is from 16 to 36 millimeters and to lobe ones. So they are different combination of the umbrella and covers. The umbrella also the same size, but the umbrella much more smaller than the regular one. the cover is much larger than the umbrella. So this is different from the regular one. This is special for these very complicated anatomies. So this is the different special. You see the umbrella is smaller, but the disc is much larger, right? So that's what we mentioned. There are 8 hooks around the umbrella, 8 hooks which can stabilize into the LA walls. And there are 8 individual U-sharp barbs. This barb, you can see the tip. The tip is smooth. This is a severe like. It's not sharp ones. So it won't injure the appendage. So and that make sure you can do several times the recapture and reposition safely. And it's an oversized umbrella. You can push that and standing against the LAA. And here we can see the barb and the hooks here. It's not very clear. The hooks here. No embolization in clinical trials, and European and Chinese clinical trials. Here are the special design for the umbrella. It's easily fully and recapture and redeployable design. We have some pictures for you see this umbrella ready to deploy. Is in vitro, and the umbrella is partially opened and is fully opened. You see, when it's fully opened, the end of this, the plane of the tip and the tip of the barbs are at the same plane of the waist. They're at the same waist, so you can see almost the same plane and floral, and you can see the some marks between these 2 markers. There are 10 millimeters length for you to measure, to do the measurements. And here is the fully recovered, and the disc is deployed, and the fully cupped. They cover the osteum. I don't know what the material is, PET is, but their design make sure the very low profile. The profile is from 8 to 10 French. Oh, that's very small. Then we can compare with other devices. This is 10 French for Emily, 14, and for the Watchman, 14. So maybe 1/3 smaller than other devices. That's much better for patients. It's much better for lower risk for bleeding. Experience, I think it's very, very good for us from Dr. Lin. This is for the bi-lobe appendage, special design of the occluder, and this is a very small appendage. This is very shallow appendage. You know, the depth is impossible for Watchman devices, right? And this is very big, very huge ones. So we can have that choices. So when we choose device, it should be 2 to 6 larger than the measure of the landing zone. That's for the regular ones. But for special ones, we could use more larger landing zone, more than 26 millimeters for the larger osteum, and for the cauliflowers, like, or chicken wing, like, too big, too small, right? Sometimes. So we can make this special device. If the OLD is presented, what's the OLD mean? The OLD means the osteum, the landing zone, and discrepancy. That means the osteum is very big, but the landing zone is very small. So for this special anatomy, we can use a special device like that. So when the osteum is of the landing more than 10 millimeters, larger than the landing zone, we can choose the special one, and it allows better osteo sealings. This is the regular standard devices. This is special devices. You can see the special devices are much larger of the disc, but a relatively smaller umbrella. So here is up to the deploying steps. We have seen that in the animation. So let's skip that. And you should remember, when you do the Watchman devices, you need pass criteria, right? So when you do the LAmbre, you should remember the cost criteria before release. The cost that made the C is the umbrella deployed should beyond the plane of the artery, and the umbrella should be fully opened and you can see that in the tip of the bar are at the same plane of the waist. So that's the radial peak ones, and you can see on the fluoral. And we can see the Perry device ceiling less than 3 millimeters. That's much stricter than the Watchman devices, right? Their recommendations is 5 millimeters, and you can also do the tuck test for the stability confirmation. So this is the cost criteria. This is the two implantation techniques for this for regular one with the normal appendage, but this for some special cases with suspected thrombus or the dense spontaneous at-home contrast. So you can make it much outsider and much shallow, anchoring, and then